Dear panelists, welcome to my presentation. Today, I am going to present a case of mitral stenosis associated with multiple lesions. Dear audience, you know that in case of mitral stenosis, if we go for short axis at the level of mitral valve, invariably we can see that the morphology of the mitral valve like a fish mouth deformity. But this is not always true in case of children. So today, my topic of presentation is that fishes are caught not always by their mouth. Let us concentrate our case. This is a 4-year-old boy presented with frequent respiratory infections since infancy. And at that time, he needs 4 times admission for lower respiratory infections. And during infancy, he was diagnosed as a case of ventricular septal defect. And after that, after 2 years of age, these symptoms are gradually decreased. Now he has only the exertional dyspnea. So when we examined, we found that he have a mid-diastolic murmur at the apex and pansystolic murmur at the left lower sternal border and ejection systolic murmur at the left upper sternal border. So from this history, we can easily understand that this is a case of VSD. Now let us see the echocardiographic clip. This is the apical 4-chamber view. You can show that this is the LA and LV is dilated, and the morphology of the both tricuspid and mitral valve looking normal. There is prominent papillary muscle and cordia looking disorganized. And the annulus is more or less mitral and tricuspid annulus is 18 millimeter, more or less same. And color interrogation shows there is a PA4 shunting left to right. And also color interrogation through the mitral valve. We can see the mitral inflow jet is exaggerated. And the inflow gradient mean gradient is 18 millimeter mercury, 12 millimeter mercury, suggestive of severe mitral stenosis. But if we look for this video clip, there is morphology of the valve is normal and valve is open nicely. So why this is flow exaggeration? Why this mean gradient is 12 millimeter mercury? Let us see so we have to concentrate to looking the subvalvular apparatus. Now, color flow interrogation in the apical 5-chamber view, we can show there is a VSD shunting left to right. And you also see there is a spare of tissue from the ventricular crest that is projecting into the LVOT, producing the LVOT obstruction. And that's and that gradient was 30 millimeter mercury. So VSD with mild LVOT obstruction causing by subaortic membrane. And this is the VSD about 7 millimeter. And there is parasternal long axis view. You can see there is a single papillary muscle. You have to see, and there is valve opening is good. And you can see there is a subaortic membrane and also a VSD. And color interrogation showing the VSD gradient is 41 millimeter mercury. And this is the short axis view at the level of aortic valve. You can see the location of VSD is approximately 9 o'clock position. So this is obviously perimembranous VSD. And if we look for morphology of the valve, this is the parasternal short axis view at the level of mitral valve. We can see the mitral valve area is 1.3 centimeter square. This is absolutely normal for this age and body surface area. And you also see there is commissures are not fused. Commercial fusion is not occur here, and the morphology is nice. And this is the short axis view at the level of papillary muscle. You can see there is a single papillary muscle. So now we can say that this is this MS is congenital MS due to parachute mitral valve. And this is the subcostal sagittal view. You can show there is a PFO. And from this view, if we move transducer clockwise, then you can see that you can open the RVOT. you can say there is a RBOT muscle band producing the obstruction at the level of infundibulum, causing the infundibular stenosis also. So our diagnosis was, this is a case of situs solitus levocardia, normal systemic and pulmonary venous drainage, atrioventricular and ventricular arterial concordance, a small PFO shunting left to right, mild to moderate MS due to parachute mitral valve, and a moderate side perimembranous with outlet extension VSD shunting left to right, mild LVOTO due to subaortic membrane, and mild RVOTO due to hypertrophied muscle bundle. So we plan for management of this patient as a VSD closure with resection of the subaortic membrane and resection of the RVOT muscle bundle and plus minus mitral valve repair. I think the mitral valve repair is not required at this stage, and we have to follow up this patient. If the patient later presented with severe mitral stenosis, at that time the patient may need mitral valve repair like the fenestration in the chordae or splitting of the papillary muscle. So take-home message is MS in children is usually congenital, and MS not always present with annular adhesion with fish mouth deformity, as like fishes are caught not always by their mouth. Left to right shunt exacerbate the mitral inflow gradient, so you cannot classify as whether it is severe or moderate mitral stenosis. Associated lesion should be searched meticulously, and presence of VSD always should be looked for subaortic membrane or RVOT muscle band. Thank you very much for patient hearing.
Thank you, sir, for your nice presentation. I'd like to request from the panelists and the audience to have any question to our presenter. If no question from the audience, now I would like to request our panelists from the virtual platform to comment on the session. Anyone from the virtual platform? Please unmute yourself and comment on the session.
Can I comment? I'm Professor Tuhin. Can I comment?
Yes, ma'am.
Okay. Thank you for giving me the opportunity. I enjoyed all the cases, and especially the cases of Dr. Choyan Sinha. It was a nice case, an excellent case, immunocompromised case, and black fungus. So total case was very interesting. And the last case, the Santosh Kumar Saha, the congenital MS. Even in adult cases, the congenital MS may present. In the adult heart disease, I saw a patient, a female patient, female doctor, 21 years. She was diagnosed as a case of rheumatic MS, but finally I found that was parachute mitral valve and there was supramitral membrane. So please do not hurry during echo. Look carefully at the valve morphology. And so the whole treatment plan was changed, and she was referred to the VSD, and finally she got operation, and now she is okay. And I want to ask Dr. Santosh Kumar Sinha that you look carefully. I think there was also supravalve membrane. When he was showing the four-chamber view, I think something was moving near the annulus, and turbulence was from there. So it is common that parachute mitral valve and the supravalve mitral membrane both present in the same cases. So please do carefully and look all aspects, starting from the color turbulence, when it starts, where it starts. So echo is not that we will do hurry. Look very carefully and meticulously, so you will not miss the cases. And valve morphology, the leaflet thickening is not only causing MS. So keep in mind that there may be, when the leaflet is normal, but gradient is high. So please look, even in adult, look whether there is parachute mitral valve, whether there is supravalve membrane. Please look carefully. And all the presenters presented their case very nicely, and congratulations to all. Thank you.
Thank you, madam, for your nice comment. But in this case, usually parachute mitral valve also association is very common associated with Schoen complex, multiple level of obstruction in the left side of the heart. That is, the Schoen complexes consist of the parachute mitral valve, supramitral membrane, yes, subaortic stenosis, and also coarctation of aorta. There are 4 components. But in this case, I think not. There is no supramitral ring, as the annulus is normal as tricuspid valve. Thank you, madam.
Thank you.